will agree with it. But the malaria actually appears to have gone down over the last 4 or 5 years. So the reason I think is, if you see the malaria, it is transmitted by the Anopheles, and the dengue is transmitted by the Aedes aegypti. It appears that there was probably a gang war. We have gang wars in the city between people. We have gang wars between animals on the roads. We also have gang wars between mosquitoes, probably. So it appears that the Aedes aegypti has won the war and the Anopheles has made a run. Okay. And therefore we see very little of malaria. Okay. So probably we used to see about at least 15, 20 patients of malaria in the season. Now we hardly see one or two. Okay, now influenza virus. This is a typical picture, a guy coming with something in his hand and blowing his nose all the time. This is the influenza viruses. So, and of course, we have the H3N2, influenza B, or the H1N1. Now, these are classically the three influenza viruses which hit us during this season. The rainy season brings on the influenza. And one must always advise most of our patients to please take a vaccine for flu. It's called Influvac or Quadriflu or whatever, around May, because that really makes a difference. Let me tell you that it can be quite a problem, when you get these influenza or the swine flu, and it's preventive, you can get almost 90% protection by that. We know it's diagnosed by throat swab test. Most of them have start with an upper and then go into lower respiratory symptoms. The lower respiratory symptoms predominate later and make it a worse situation with breathlessness, cough, and they should be investigated for flu viruses. So you should get a swab test in anybody whom you feel has fever of more than 3-4 days duration and is looking bad. You see that bad throat, you rather tell him, boss, pehle test kar le, baad mein we don't know what will happen. Blood workup, the usual, we all know, we do that. And chest x-ray to look for shadows in the fluffy shadows in the chest x-ray to tell you of swine flu. The moment you see that, just take your paper out, make a referral note and send him away. Treat with, of course, antipyretics. Oseltamivir or Fluvair can be given. So in that season, we were giving Fluvair left and right. It does make sense, because it's very difficult to diagnose these viruses anyway. So Fluvair won't do any harm. Okay. The third thing is steroids. A lot of people don't want to use steroids. But let me tell you, the only thing that works is steroids. What happened to COVID? All of us know. We were all there. What worked finally? Dexamethasone. End of the day, you had so many things up and down. Fossey made so much money. And finally, the British people said, boss, only Dexa is working. So you start using Dexa and patients got better. So steroids are the mainstay in most viral illnesses, and steroids somehow tend to stabilize the virus, or they help to reduce the lysosomal instability. Of course, you monitor vitals, SpO2. It's a good thing, and to have this SpO2 thing in the clinic all the time. Patient feels you're doing something big. When you look at its saturation, look at it hard, look at it 3-4 times. So kami vatta ye wo. So he feels, oh yeah, I'm really ill. So he'll come back to you. So you have to wake up show. Most of the times, patients require this. They require these psychological things, which of course Dr. Rupa Agarwal tell you better than me. So here we are. So chills and fever, Samantha Fish. So we have the fever with chills. When we were actually students and all of us were studying, I think all of us know that chills was something we always associated with malaria. And fever with chills was malaria. Unless proved otherwise. I remember that all the time when we were actually studying medicine. Fever, chills, what is the cause? I was just shout, malaria, malaria, malaria. So that's what it is. So malaria is something that we must discuss. So we know as malaria, we all say, with people who are quite famous, malaria does not need any introduction. Yeah, we've been seeing malaria for very long. And for an Indian, malaria is like everyday occurrence, was. The Vivax and Falciparum are still the prevalent parasites in India. We were having Vivax for a long time. Falciparum, remember, appeared for the first time sometime in 1986 in Bhiwandi, a very called place next to us in Mumbai. That's where the first outbreak of Falciparum came, and since then it has been everywhere in India. but that's where it started. The fever pattern is generally once a day. Generally once a day, may range from 36-hour cycle, but also may come as a continuous fever. So generally once a day with fever, with chills and bad, and you will think, yes, it's malaria. If it's a continuous fever, also don't rule it out. You may not think of it first, but yes, don't rule it out at all, right? The second thing is peripheral smear during fever is the most accurate test. Now, having said that, how many times can you do this peripheral smear? I remember as residents, we had to run, take a smear, keep it, make thick smear, thin smear, send it to the lab. All those things nobody does now, because they will coolly keep it aside and say, Baba, amala mahit nahi, Dr. Alevaras karta. We are not allowed to report it. So all your effort goes waste. But whatever it is, you still have to do it. Rapid malaria test is something that we've been doing for the antigen, as all of you know. The rapid malaria test is sensitive in only about 70%, and in falciparum, even less. So rapid malaria test is not a test which rules out malaria. It can help you if you find it, very good. But it's not a test that is 100% sensitive. So if you are still doubtful, I think one would depend more on our clinical acumen. And what's the harm done with giving artemisinin? We have Cinriam, 1 tablet a day, 3 days. All of us know combination of RT and artemisinin. So artesunate, I'm sorry. You can give it. Yeah. And of course, injectable, we have the good old artesunate Falsigo, which is available. So that you can give. So easier to treat a malaria than try to diagnose it. If you are really thinking that it's a malaria, it's your clinical judgment. Still, I don't think anybody would say, why did you treat malaria? Why do you treat with this tablet? Because I think that it still makes sense in India. If you're finding fever and not coming down, treat malaria. You never know. So that is one thing that you could do. So the other thing is, all of us like to go hiking and go everywhere. This is rainy season, beautiful time to go out hiking, go here and there, get into these small ponds and try to swim and have a great time. So this is the season that we get. And then, of course, you land with leptospirosis. It's an acute treponemal infection caused by the Leptospira genus. Leptospira, treponemes actually, as you know, Treponema pallidum or, the syphilis and all that, they're all spirochetes. Spirochetes are somewhere between the bacteria and the viruses. They're organisms which are a little bigger than that and somewhere near the parasite. Parasites are much bigger, of course. Yeah. So they're not classically bacteria. They're classified as spirochetes. The mode of infection is skin lesion or conjunctiva. So most of the times when you get into the ponds and you get into contact with the contaminated water and there's a small abrasion there because you keep swimming and you get a little hurt with some of the stones and this thing appears, it goes in, or, somebody splashes some water and it gets into your eye. That's how the conjunctival thing comes. So that's how you'll get it. Symptoms and signs, there are 2 types actually. One is the anicteric leptospirosis, something without the jaundice. Okay, this is more common. It's a biphasic presentation. Initially, you're a septicemic phase. After 2 to 20 days of going there, you might get high-grade fever with chills, abdominal pain, headache, and myalgias. Blood isolation at that time with the leptospira antigen is possible, but requires a high index of suspicion. I think it's very difficult for anybody to do it unless he's looking at leptospira at that time. After 2 to 3 days, the symptoms resolve. And they're followed by the immune phase. That is recurrence of these symptoms again, followed by this time a nausea, vomiting, diarrhea, and an adenopathy. Most of the times, this also is a self-limited phase and resolves, but tell the patient to take up to 1 month for recovery. So anicteric leptospirosis, if you have diagnosed it, please tell the patient it's going to take some time to get better, and you will get the symptoms back after about maybe 10 days or something. You start getting the symptoms again, and at that time, you're nausea, vomiting, and all that. And this is the way the illness goes. You can, of course, reduce it, doxycycline, but still. Icteric leptospirosis or Weil syndrome. We used to do the Weil-Felix test for that. So Weil-Felix is the person who's found it out. So altered liver and kidney function is what is icteric leptospirosis. So you have a patient, looks very feverish and has body ache, myalgias, you don't look good, and you've done all the tests, you find his kidney function slightly deranged, his liver function deranged, think of leptospirosis. Almost 90% you'll be right. Okay. think of leptospirosis. Rarely you can get a hemorrhagic pneumonia, hypertension. Mortality, if you get all this, is in the range of 5 to 40%, which is why you must act fast. So if you have a patient who has altered liver and kidney functions, I think get the test done, start him on doxycycline, doesn't no harm done. Lab findings, white cell counts will increase, you have uremia, left range, CPK will be elevated, and ELISA for leptospira will be positive, which will tell you about the antibody. Now, treatment, doxycycline works excellently well, morning and night for at least about 10 days. Penicillin 1.5 million 6-hourly in those who are pregnant and those who are breastfeeding. As you know, we can't use doxycycline. Ceftriaxone works equally well. So in your clinic, you can give Monosef 1 gram twice a day, 5 days. All right, it'll work equally well as the doxycycline. Those who are actually moribund, don't look very well, can't take the tablet, okay? So give the Monosef injection. If no jaundice, usually it is never fatal. Remember that. If no jaundice, leptospira is never fatal. With jaundice, of course, like I showed you above, up to 40%. And if it's greater than 60 years, push the patient away. Greater than 60%, you have a guy 64, 65, renal function deranged and liver function, don't keep him there. Baba, go to somebody else. Okay. So send him away to the hospital. Right. So that's how you have to be worried about. So these are the infections you'll see, you'll see lepto and you'll see just malaria. And of course, you look at the 1 minute. I think I missed something. Did I? Yes. Yes, this is something I missed. So dengue. So dengue infection, we know now we are swarmed by dengue, really swarmed by dengue. I presently have got 22 patients admitted with me for dengue. So it's caused by the bite of the Aedes aegypti mosquito. Previously, we used to believe that, water which is stagnant is causing it, and there was hardly any water in June, July, or almost till end of June, let's say. But we still got dengue, still got dengue. So maybe there's some way it is spreading other than that. So dengue spreads by the bite of the Aedes aegypti mosquito. 4 variants are known, the DEN 1, 2, 3, and 4. The present epidemic is supposed to be DEN 2. Presents with high-grade fever, body, I think all of us have seen such patients, redness of eyes, severe weakness. This happens with any patient. First, get his hemogram done. You may do a dengue NS1 if you feel that you better rule it out. Otherwise, do a white cell count first and a platelet. You've got good platelets, maybe repeat the test later on. There's nothing going to happen. So only if you feel the platelets have dropped, then tell him the dengue karna padega. Okay. Diagnosed by blood test, we all know NS1 positive first 5 days, IgM after 5 days. IgG either indicates an old infection or sometimes a secondary dengue. When only an IgG positive, again patients platelet dropping, old history of dengue. This is secondary dengue, and remember, secondary dengue is a very serious infection. Secondary dengue, like your leptospira icteric, can get rapidly worse. I have lost 2 patients with secondary dengue. In 2 days, they just folded up. The whole body started looking yellow, output 0, gone. Okay, so secondary dengue can be very serious. So if you have IgG positive and lower platelet patient has history of dengue, he needs ICU. Okay, right? Now, complications of dengue we know are usually what we see nowadays are the thrombocytopenia-related complications, which are the hemorrhage and all that. The shock usually is called a dengue shock syndrome. It is usually due to capillary leak. It is not really due to the hemorrhage. But capillary leak, what happens is because of the dengue, you get increase in the pores in the capillary, then the fluid gets out. And that's how you get the 2 things. You get the hemoconcentration, which is increase in the hemoglobin. And of course, you'll get the hypertension. Hepatitis is also known, but it's mild. It can become severe. Intracerebral hemorrhages are due to thrombocytopenia. All of us remember the first 2 years of dengue were pretty bad. We had so many patients dying of intracerebral bleeds. Later on, I think it reduced with the new variants. Treatment, of course, is symptomatic. All of us know. we have to treat and watch for the platelet count, hydrate the patient, keep a good watch on that. Hydration most important in remove because of the capillary leak. Patient must get hydrated and you must see that enough hydration going on. Antipyretics to reduce the fever and steroids, of course, one of the mainstay of treatment. Remember that steroids you must give in all patients who have lowered platelet count below 150. The reason being that all hematologists and infectious disease together believe that what happens in dengue is called as a transient ITP. You know, what happens with transient ITP is the virus gets into the body, it goes and gets stuck to the platelets. The body thinks that this is the virus and it kills both. And it's a transient phase. So it's called a transient idiothrombocytopenic purpura. So a transient ITP is what it is. Treatment is steroids. You can give dexamethasone or you can go with the Vizolone, whichever one you like. But that definitely helps. So steroids, what they believe actually is that the steroid tends to separate the virus and the platelet, and that's why only the virus gets killed. So that's what they believe. But nobody's proved that, but that's what they believe. So that's it. Platelet transfusion is only reserved when the platelets go below 10,000 and there is a risk of bleeding. Okay, so platelet transfusion must be avoided in most patients for two reasons. First is that they believe that platelet transfusion itself is antigenic. It can cause, again, reactions in the body and platelets may go down further. And the second thing is that the platelets are quite expensive. You have a single donor platelet costing now up to 15 to 20,000 and will stay in circulation only for 24 hours because the half-life, as you know, of platelets is around 24 hours. So it will stay only for 24 hours. So it's quite an expensive treatment and may not be required actually. It doesn't do any help. So avoid it unless it's going below 10,000 or maybe I would say, okay, 20,000 sometimes, but 10,000 would be what I would do for most patients. Yeah. So that's about dengue. We're seeing now, these are the common infections we're seeing now, you know, viral infections. We're seeing flu, so many flus we see, and we see dengue. Occasionally, we do see leptospirosis. It's not very common, let me see, tell you. I've seen 3 patients in the last 2 months. And of course, we have the things, you know, what happens is people travel a lot, you know, nowadays. You see this summer season, everybody went for what's called as revenge tourism. 2 years because of COVID, they couldn't move anywhere. So they went in for revenge tourism. They start just going out, you know, all hotels full, everything full, visit all old places and all that. And sometimes ended up visiting old houses like this. So what happens when you visit old houses like this is you get bitten by some ticks and then you get something called typhus. So rickettsial infection is something that's very common, not in Pune, but you know, you people from Nagar and that side, you know, they will tell you they see a lot of rickettsia in this season. So these are the typhus groups of diseases. Out of that, the R. prowazaki, you know, was the one that rickettsia prowazaki was due to infected lice. Transmission was through infected feces of the louse entering the body via scratching. Infested with the louse feces or inhalation of dry louse feces. This is what usually it is, but we see more of the endemic one, you know, the one from rat to flea. Okay, so this is just for your information. That prodrome of malaise, cough, fever, followed 10 to 14 days by high-grade fever with chills, flu-like symptoms, delirium, macular rash on the axilla, which can progress to the trunk, and it can progress to a hemorrhagic rash with hypertension, uremia, and seizures. So this can happen with the patient. Lab, of course, shows thrombocytopenia, again, raised LFTs, proteinuria, hematuria, positive IgM antibody for rickettsia as diagnostic. Treatment, doxycycline, if you can't use it, chloramphenicol in pregnancy and breastfeeding. The endemic one is the one that we see from rat to flea, which I showed you the old houses, you know. So that patient comes with fever, headache, myalgia, maculopapular rash, mainly on the trunk, palms and sole, and on the trunk. Your palms and soles will be spared. So if you see a rash, which is mainly on the trunk and nothing on the palms and soles, and patients with fever, headache, and all this, think of rickettsia and look to an antibody test. It's readily available, the rickettsial antibody test. You can do it and you can get the IgM positive and then treat according. Again, doxycycline, But fortunately, see, ciprofloxacin works and azithromycin. So pregnancy, you can use azithromycin. So you can use it in those patients. Ciprofloxacin readily available, so you can use that also. So generally, doxycycline is the preferred and the best drug for this. So rickettsial infection, that is what we actually use most of the time. Okay. So the other causes of fever, we know, I'm just enumerating that because I've written the cause of fever that you have bacterial, viral, and whatnot. So we know that, you're looking at urinary tract infections, you look at pneumonias, and we all know that you have to treat as desired with adequate doses as per the cultures. Always, if you feel, start with a broad spectrum drug. Always do cultures of urine and sputum. Look for odd signs, in the patient, whether patient's getting liver function derangement. Then you have to look for whether it's going to get worse with something going into early septicemia. So all these things you must see. You're giving injections to the patient's high-grade fever, and he's not eating well. Get alerted. Has he got some kind of icterus? Look for that. So all these things that we must do in our general practice, that we have to look for all this, and as nowadays, I think all the bulk of the patients are with the general practitioners, and I see general practitioners treating so well, that you must, and most of the, when a patient comes to me, he's done everything, not left anything to me to do, except nod my head and say that treatment is good. So you have to do all these cultures of urine sputum and look for odd signs. Be aware of the medication that the patient is using. So always ask the patient, what medicine is he using? See, you don't ask the patient. Sometimes this guy is having probably anti-epileptics. You don't know. This guy is on warfarin. You don't know. So please tell him, get all the medicines to me, please. They will tell you, me get this, that, whatever. So I will tell you, I'm the diabetes, but me burn the kila. So you have to worry. This guy might be having a sugar 500. Okay, that's why he's dehydrated. So this is possible. Interaction with drugs is also known. Okay. And most importantly, I would say today that you please use Dr. Google. See, it's not possible for any of us to know everything about medicine. And as years of practice go by, you have less and less time to look up the books, and it's not possible. I mean, for all that old style physicians that we used to see every evening, pipe in their mouth and, opening some book and all that, that's all passe, we don't have time for all this, there's so many things to do. So use Dr. Google whenever you're little, sort of not very confident, so just write down symptoms and quickly look at Google what's possible. So that, so you should know that our patient gets a report to you and you're not sure. Look at Google. What's wrong? Okay. But don't diagnose by Google. If you diagnose by Google, you end up becoming a patient yourself. Because a lot of patients come to you due to Googleopathy. Okay. They've seen Google and some Google has told them you have cancer. They come running to you. So even for a small boil on their hand. So use Google, but only for your information to help you, not for diagnosis. Fever, as we know, can be a headache. I know. And I agree. All of you have seen fever and you've been harassed by fever, I'm sure, by last month and a half. The only thing you see outside OPD, guys, fever, and whatnot. And then, all that thing, I think all of us have been facing now. And it can be a real headache. Patient comes, फायदा होत नाही, तापच उतरत नाही, उलट्याच होत, अरे काय headache झाला, you say, bloody, where I have got into this business. So that's what fever can be, a headache in this season, really bad. And if it is bothering you, then please send him away to somebody, you send him to me. And if I get sick of him, I'll send him to the infectious disease specialist. So we have ways out, so don't worry. So if he was getting headache, if the fever is getting a headache, get rid of it. So send it to somebody, tell him, Baba, tuझं डोकं त्यांचं डोकं खातो. And for me also, if it's there, I send it to the ID. So finally, you see, in medicine, you can't do everything. And believe me that sometimes, you start with looking at a patient in a particular way, and sometimes it doesn't work, and then you wonder what it is, and outside in your OPD, another 15 people are shouting. So what to do here? It's tough. Saude pude. Okay, don't get worried here. See, nobody will pay you to be a hero. Let me be very clear with all of you. Nobody will pay you if you've treated fever. Kiti chan aushad dilo. The moment one of your medicine causes a reaction, he will shout in that OPD only. So don't think that patient is going to give you anything, They are most, ungrateful people. So forget about it, right? So I'll give you a little pause because, you need the pause. So you got a lot of knowledge. So maybe you can require a pause and then maybe, we need to go back and then see what to do. So we're coming to the end of the discussion, giving you too much of gyan, I think. So then finally, this is the patient coming to him and asking, what is the use? I'm coming to you and you're not treating my fever. I'm not getting better. What do you think of yourself? This is what usually happens, And how do you approach then a patient with fever? So as soon as the patient comes, start listening, duration, and keep interrupting that fellow, please. He can start some kind of big lecture, and you won't get anything out of it. So quickly start asking, किती दिवसापासून आहे, किती जास्त आहे का, बरं त्याच्या आधी काय झालं असं. Keep on asking him. Don't, उसको MCQ type पूछो पापा. Otherwise, you can't finish with these patients. Ask him history of travel, very important. Like I told you, going to old houses. Ask him history of drugs, tell him to get all of them. Is anybody in the family having similar symptoms? Tells you about viral and other things, very easy to diagnose them. Comorbidities which the patient has, which tells you what to do, alerts you about it. And medications taken, and are there allergies? You have to ask the patient. Reaction you have to ask, all these things. Very, very important. Examinations, go for the vitals. Always look for icterus, look for edema, look for rash, look for nodes. Do a good systemic examination, which is part of what we've been taught. And of course, depend on your lab workup. If you feel fever more than 2-3 days, or there's a high suspicion on day one, you can do it earlier. Get all the investigations done. Better to go, at least you know that what you're treating. And treat, of course, with the suspected cause, if you know what it is. Start with antipyretics. Tell him to take enough fluids. You may start either antibiotic if you feel it's an abscess or looking like a pneumonia or whatever. And follow up closely for new symptom sign. Refer early, don't refer late, because by the time the patient gets worse, the first thing they do when you go to the hospital is some stupid resident in the night will say, "Oh, the 4 divas kele na, the patient serious na." Finished. Next day, the whole crowd is there outside your OPD. So this is with the problem. So refer early. If you think this fellow, now I think all of you are so many years in practice, looking at the face that this is a guy I don't want. So send him away, yaar. Kya fayda hai? Forget it. There's so many patients are there anyway. Be aware that existing trends of disease and treatment. Be aware what the treatments are at present. Be aware of what diseases are. Like I said, dengue is there nowadays. See what, ask with your colleagues, Baba, as a patient, it helps, it helps to confer with colleagues. It also helps to share information, because that's the way that we all have to coexist, because here, all the patients are now not very kind, they can come and cause all kinds of problems to you. Investigate early, repeat all the tests if necessary, and that is the way to treat fever. You have to investigate early, repeat all the tests if you feel that you are having some problems. So repeat it again. Okay, so that's the most important thing. This is how we treat most of our patients. I don't need to give you big lectures on how to treat fever or what is life cycle of malaria. I don't think, and at 3:30, I think most of us want to sleep, so I don't want you to sleep anyways. All right, so thank you for a very patient hearing. And like I said, tapacha tap noko, at the patient. See, Baba, tap deto hai, noko mala Baba it's tap. Saude pude. Okay. So thank you all for a patient hearing. If there are any questions, I'll take them.
Yes, sir. Thank you. Thank you very much. Now, this is the time to check how the participants understand this fever. Love Ajkal, fever Ajkal. Now, this is the time for quiz. I request Dr. Gayatri to please send a link in the chat box. So you can take a rest for a few minutes. We will have a question answer session after the quiz.
Okay.
So, thank you, Dr. Jyoti.
Yes, all participants get ready. You have 5 minutes time. There are 10 MCQs in the
lecture.
Okay. Be ready. Yes, Dr. Gayatri, please
Yes,
send the
I will
link.
post the quiz link in the chat box. There are 10 easy questions and you have 5 minutes to solve them. The highest scorer will be awarded a prize. Please note that if there are 2 or more people with highest score, then the person who has submitted the quiz first will get the prize. So please be quick. Now I'll post it in the chat box.
Be fastest first. So get ready.
Yes, I have posted it. So your time starts now.
Wow, we have one person already answered the quiz.
Okay.
People are really quick. We'll wait for 2-3 minutes more.
Okay. Last 2 minutes. Please type done in the chat box after you finish your quiz.
And Dr. Gayatri, I think we have got quite many answers.
Yes.
Should we start with question? And we'll keep the link open for some more time.
Yeah,
But
for 2 minutes,
we
and
can
then we'll.
start with having the questions with Dr. Dr. Jyoti asking sir.
Yes.
Yes,
Is
sure.
that okay, Dr. Jyoti?
Yes.
Yes, so we'll have a question answer and we'll wait for the few more people to submit the quiz. म्हणजे YouTube वरचे काही सर आपल्याला 100 लोक इथे जॉइन झालेली and almost some 24 people had joined on YouTube. So
Oh, that's nice.
yes. So
Okay, sir.
yes.
Shall we start for question answer, sir?
Yeah. Okay.
There are many compliments for your lecture also, and there are so many questions also. So
Yeah.
let's start with questions. There are many questions regarding steroids. So what is the dosage and the duration for steroid in the dengue fever and also in pediatric? And shall we give steroid in fever tapering? Is it necessary to taper the dose of steroid in fever?
Yeah. Thanks. Yeah, good question. Actually, see, steroids, you have to use. See, we used to use 1 milligram per kilogram in autoimmunes, but I don't think you need to go that high. Probably 0.5 milligram per kilogram. So if you start with somebody, maybe use 30 milligram of Vicelon is good enough. Start with 30 milligrams. You can give up to 4 to 5 days. After 5 days, please taper it down 20, 10, and then reduce it. The main thing to note is that if you find that using steroids second, third day, the platelets have started going back to normal quickly, taper it off fast. Okay. If you feel they're still high, then you can go give it up to 5 days, definitely. And then taper it off slowly. Okay. So giving steroids is not a problem. Pediatrics, I'm not too aware of how to use it. I haven't seen, I'm not a pediatrician. So I think the pediatrician would best answer whether they use steroids. Now a lot of times, we have this kind of taboo about steroids and patients have taboo about steroids. And please, I think everybody should take his time out to tell patients that the only thing that will save you when you have a big problem with steroid, you have a bad anaphylactic reaction, it's steroid, you have a bad viral infection like COVID, steroid, you have probably a huge kind of sepsis, we use steroids. Okay, you have a bad kind of autoimmune, multiple sclerosis, all of them, you have to use steroids. Only the reason tell them that why steroids they are scared of is because of history. Historically, what used to happen about 20, 30, 40 years back is that, steroids were the only tablets available. The other tablets were very few, few painkiller like paracetamol, brufen. And steroids used to work like magic in rheumatoid arthritis, asthma. As we all know, steroids do still work like magic. And what happened was that people started misusing the steroids because they were available off the counter. They used to buy in bulk, That time I remember people used to take steroids like, you're taking chocolates, so they take 4 or 5 at a time. And then they used to feel better, keep working. And then after a few months, they start becoming big, their face becomes big. And everybody, the doctor says, you're using steroid, that's why it happens. So this tablet got into disrepute, So we have to use steroids selectively in certain patients. And I told you that the only thing that works presently is looking like steroid because it tends to reduce the transient ITP that we know. Mm-hmm. And of course, yes, you have to taper steroids. So my take is use it for 5 days, taper it out the next 5 days.
Okay, sir. And sir, in dengue, how steroid doses given in IV? Should we give Dexa in IV?
Yeah, the advantage of giving Dexa actually is it's a longer acting drug. If you want to use the hydrocortisone, it's a very short acting drug. Hydrocortisone is very good for allergies because you want a short acting drug. For longer acting, I think the Dexa is the better drug to use.
Okay. Sir, please shed some light on CBC values in fever and also diagnosis from it.
Yeah. Now, see the most important thing, very good question actually. See, when you look at a CBC, please don't look at the total count. So if your total count may be 20,000 and your neutrophils are only 50, this is a viral. Okay. So anytime you look at a CBC report, please look at total WBC count. If WBC count is way below 10,000, maybe 4,000, 5,000, 6,000, would definitely tell you that it's not a bacterial infection at present. Well, bacterial infection, unlikely. But always please look at the neutrophils. You have a high count with neutrophils of 60, 70, 72, it's always viral. Look at the bottom of the report. If it says reactive lymphocytes, you are at 100% viral. Okay, so look at all these things. Sometimes you will count as high as 50,000 having differential of 70 and all that. These are what we call leukemoid reactions. Leukemoid reactions are reactions which look like a leukemia. Body overreacts. You'll be surprised to know that some patients, you take their blood and their counts come 25,000. That's because the body and the white cells tend to go and accumulate at that site, and then they suddenly increase in response to any stress. After all, how do you get leukocytosis? It's the body's response to stress. It's the macrophages and the other things going to the site and trying to take the infection, limit the infection, or eat up the bacteria, or whatever you want to say. So they are what we call as phagocytes. We call the WBC as phagocytes. So sometimes you can get an abnormal reaction from somebody. So important thing is, don't just look at I tell everybody, don't look at the hemoglobin. Somebody came to you with a hemoglobin of 7 and you tell him, we'll give you iron tomorrow. And then you find his MCV or mean corpuscular volume is 110, which tells you it's a B12 and folate deficiency. And the iron is actually 90 or 100. So always look at the report completely. Okay. So look at your hemoglobin. If your hemoglobin is low, look at your MCV. If your MCV is high, it is always megaloblastic. If MCV is low, it's iron deficiency or thalassemia. If you find a patient with a HB of, let's say, 9, and the patient's MCV is, let's say, about 68, 69, ask the patient, very importantly, if it's an old lady or something, or it's an elderly lady, ask her that what is your hemoglobin during pregnancy. She'll tell you maximum it was 10, which means that these are probably thalassemia minors, possible. So that is how we look at report. WBC reports, you have to rely on how high, and of course, you have to repeat it, but WBC about 3,000-4,000. Remember that virals you can get a count as low as 2,000. Not going to mean anything. Don't get worried. And the important thing for all of you to remember is, once you'll give the steroid, the WBC will jump. So the first time you give Vicelon 30 milligram, do the WBC, the count 2 days later, your WBC count from 4,000 will go to 14,000. Don't start antibiotic. It's due to the steroid. Okay, it will come down on its own. Okay.
Okay. So there is one more question. Dengue, typhoid, malaria, chikungunya, all are negative, but HGPT, HGOT, CRP, ES are raised. What does it denote?
Well, in this case, you probably call it a viral fever with a mild hepatitis.
Okay.
Hepatitis is because you got the SGPT high. So you call it, all virals will cause a little higher SGPT, SGOT. So it's probably a viral with that because your CRP is high. When CRP is high, you're more favoring a virus. So you're looking at fever with high CRP, with LFTs, acute presentation, more of a viral, which is one of these other, maybe cytomegalo, or you have so many viruses, arbo, or whatever.
Okay. So can we advise dengue antibodies in first 5 days?
See, the thing is, you don't know how many days the infection is. So if the patient came to you on day 1, it's always better to do dengue NS1. If your NS1 is negative and patient keeps on getting fever and the platelets are dropping, at that stage, instead of NS1, do an IgM. Remember that there is what people now believe is there is a slight gap between the NS1 and the IgM. So you have NS1 negative, IgM negative, patient's dropping platelet. Next time you do the IgM, it comes positive. So that's very important. So between probably 5 and 7 somewhere, So your NS1 may go off, but your IgM hasn't come. That depends on the body's immune response. So if the immunity hasn't come to the level that the IgM will show up, you may still get the IgM negative. What we'll tell you is if dropping platelet and fever, please think dengue again to repeat the IgM.
Okay, sir. Sir, there is question about typhoid fever. When to advise Vidal test to diagnose typhoid, and are there any other tests to diagnose typhoid within the first week of fever?
Yeah, the best test, of course, is, as all of us know, is blood culture. Nothing is better than blood culture done during fever. You get the culture of salmonella on the blood is the best test. Next test, as all of us know, is the typhus IgM, the IgM for typhoid. It comes positive generally after 4 to 5 days of illness. Some people believe that typhoid IgM is a better negative predictor. You have typhoid IgM negative, you can safely say that this is not a typhoid acute at least. Vidal test, as we all know, is an antibody test. It takes about 8 to 10 days to develop. So Vidal is, of course, to be done only after 8 to 10 days of illness. Positive Vidal on day 1 of fever is more like a cross-reactant. You get a positive Vidal in malaria on the first 3-4 days. Okay, that's called a cross-reactant. It cross-reacts with that. The malarial antigen cross-reacts with the antibody. So you get that positive. So first 5-6 days, if you get a positive Vidal, neglected, but like I said, you don't know how many days the fever is. The best test to know is if you have a rising titer of Vidal, rising titer, extremely important. You have a titer to 120, after 3 days, it's gone up to 240, 100% typhoid.
Okay. Yes, sir. And how to treat the case of fever and gastroenteritis?
Yeah. Well, how to treat is, see now there are 2-3 ways of treating. First, ask what are the motions? Are they watery? If they are watery motions, very unlikely you are having amoebic problems. Okay. So what you would do is go into whether it's a viral gastroenteritis. Patient see, whenever you have fever with gastroenteritis, remember fever with gastroenteritis comes under what is called as invasive fever. So invasive gastroenteritis. Invasive gastroenteritis is either viral or they are bacterial or whatever. But if you have a patient having a watery green stool, watery is 90% viral. And nowadays you get adult rotavirus. All of us know. Like you have children getting rotavirus, you have adult rotavirus. So adult rotavirus is also something that we know. Okay. And of course, otherwise gastroenteritis, I think we all know we treat with a combination of quinolone with ornidazole or whatever. You can go in for doxycycline. If it is watery, I think I would prefer a doxycycline to giving the ornidazole and ciprofloxacin. So that I would definitely prefer. And otherwise, nowadays, just to tell you all, rifaximin is coming as a very good drug for diarrhea. So remember that your patients have a little diarrhea for a longer time, rifaximin works wonders. So give rifaximin in those patients.
Okay, sir. Sir, next question is, why not leukocytosis in enteric fever being a bacterial infection?
See, basically, like I said, a lot of times, when you have a fever, like you have enteric fever, the fever actually starts in the Peyer's patches, in the lymph nodes, as we know. And because it starts in the lymph nodes and then from there it grows and gets into the blood, it takes its while. And a lot of classically fevers, like we know enteric fever causes bradycardia. Okay. And what is the hallmark of enteric is not leukopenia, it is called neutropenia because it starts in the lymph node. So you may have a white cell count of 14,000 with a neutropenia, which is more like a Vidal. So it's not leukocytosis is not seen in typhoid. It's a neutropenia, which is classical. Okay. But let us all believe now that, this is called as, pressure of antibiotics, pressure of everything. Antibiotic pressure is causing all bacteria, everybody to mutate. So you'll get all new forms of presentation. So don't believe what is in the textbooks. Most of the times you will be surprised, but it happens. So be aware of it, keep doing the tests and treat as per your clinical suspicion.
Okay, sir. There are a few questions on NS1. So is NS1 positive in all 4 strains of dengue infection?
At least at present, because it goes for the antigen.
Okay. And specificity and sensitivity about NS1 test? See,
NS1 in dengue is almost 90 to 95% specific and sensitive. The present tests are very good. So it's unlikely that you'll miss it if it is there.
Sir, kindly comments on about the sensitivity and specificity of Belflix test for rickettsial fever.
Yes, good question. Actually, see, the wild Felix, as being an antibody test, may not come positive initially. Okay, it is a very specific test. When we say sensitivity and specificity, we should know that sensitivity is the number of times that it will catch it positive. So if you have 100 and it catches it 99% time, it's 99% sensitive. Now, when it catches only the, let's say, leptospira and nothing else, it will be 100% specific. Like, we'll say that Vidal is a non-specific test. Why? Because it catches something else also. Okay. Or this test, the NS1 is a very sensitive test because it's highly accurate, and specific. Okay. So the wildfire X can be up to 70 to 80% specific in most instances. And generally, if you have a wildfire X negative at 8th or 9th day of the fever, you can safely rule out a leptospira. Although the blood cultures are the best, but blood culture are very difficult to obtain. Urine cultures also, as you know, are done.
Okay, sir. Sir, RT-PCR for typhoid, is it diagnostic test at the earliest? Typhoid ke liye, RT-PCR.
Well, you see, as you know, the RT-PCR tests, okay, the polymerase chain reaction tests which are there, they depend on certain targets in the either the virus or the bacteria. Okay, and I am not aware of any very specific test for RT-PCR being available at present. Otherwise, it would have replaced the IgM long back, because blood culture still remains the best test.
Okay. Is there any more questions? Participants can ask or they can raise their hand. So there is one question from Dr. Sagar. What is the current updated medicine for COVID?
Yeah, see now COVID, as you know, that the present medicine, of course, which has been in US for some time, the Paxlovid. The Paxlovid is a drug which now people use very regularly for COVID and appears to have a high degree of sensitivity and specificity. So Paxlovid, I'm not really aware of what the exact dose is, but that is the drug that people are using presently. And it got good results. Paxlovid has done well in most of the trials there. So Paxlovid, I think, is the present drug that's recommended.
And sir, after how many days of fever we can give steroid?
Why do you want to wait? You can give from day one. Okay. If you believe it's viral, start with steroid. See, the question is, steroids, what are the functions of steroids? See, when we say NSAID, what is NSAID? Non-steroidal anti-inflammatory drugs, which means that steroids are also anti-inflammatory. They're also antipyretic, and they're also in part analgesic. Okay. So they are also antipyretics, So if you feel that, that your fever is high and looks viral, see, the catch is there. If you feel it's viral now, then don't hesitate to use steroid. If you use in bacterial, nothing will happen. Let me tell you, there are people who tell you the infection will flare up. It never does flare up. Because when there's a flare up of infection, first thing you use is steroids, because you want to stabilize the lysosomes. So whatever it is, depends on your clinical judgment, and depends on who is the patient in front of you. You have a Google educated patient, Googleopathic patient, don't give steroid. Tell him, Baba, aisa pehle ye le lo. Okay? Because he will go and then he'll go to Google and call you midnight saying that's how you get steroid. This is do this. I don't know. I get reactions. So all that. So avoid that fellow. But if you feel the fever is high, you want to use steroid, please use it. No problem.
Okay, sir. Thank you. Still, there are a few questions. Can we continue, sir?
Yeah, let's give it what's time. Okay, another 2 minutes.
Are there any side effects of COVID vaccines?
Yeah, see, there was a big debate about Pfizer, all of us have seen. I think that is where the question is coming from. Because all that everybody's seen on WhatsApp, that interview with the Pfizer fellow and all that was revealed. Now, if you I saw with the Omicron variant, especially, A lot of people took the vaccine and in a week got COVID. I am not saying that the vaccine caused COVID, but there was a likelihood. You see, I had so many people, especially the old people, took the third dose of vaccine and in 10 days they got COVID. So we don't know whether they are there. The local side effects, we all know, maybe pain and fever and other things. People got idiosyncratic reactions to COVID vaccine. There are plenty, but nothing major. Let me tell you that. At least with the AstraZeneca, I don't think anybody had major issues. I mean, I have yet to see a patient getting admitted to hospital for COVID, after COVID vaccine reaction.
Okay, sir. Okay, sir. Sir, last questions.
Yeah.
How much tighter in Vidal needs IV antibiotics?
No. See, IV antibiotics will more depend on how bad the patient is. Any patient that is, looking moribund, okay, I think you'd rather give him intravenous. The intravenous dose, as you know, is ceftriaxone 2 grams. Okay. Nowadays, a lot of patients tend to add azithromycin to it. So that is what is the usual dose of this. And it is to be given for at least 10 to 15 days. Remember that, number one. Second thing, after you've given the antibiotic, tell the patient takes 3 to 5 days for the fever to go. So don't tell him to come tomorrow and say, no, there's fever still. Oh, tell him it's going to take 5 days. Till then, take antibiotics. Keep on taking it. Okay? So that is most important. And the second thing, of course, is with IV antibiotics. I mean, it depends on how you can give them. Sometimes you can, you cannot, depending on the place. But orals work pretty well. Somehow, cefuroxime was touted to be a very good drug. Hasn't worked that well, As oral drugs go, combinations of cefixime with ofloxacin and so many things are available. They haven't worked that well. If you have a diagnosed enteric, I would rather tell him that, Baba, you need to take intravenous for 5 days at least, unless he looks all right, and you want to give him either cefixime or flox combination, or you want to give him an oral cefuroxime. So that would also work.
Okay, sir. Thank you very much.
Yeah.
It's a really enjoying session, sir. It is very much informative, and you have given a clear-cut instructions to how to treat a case of fever. So now everyone is very curious about the results of the quiz. Now I hand over to Dr. Prakash Mahajan, who is the president of Muktaa Charitable Foundation. Please, sir, declare the results of quiz and give vote of thanks. Over to you, sir. Dr. Prakash Mahajan, sir.
Yeah, Jyoti, I'm waiting for somebody to pass on to me the winners.
Sir, I have
Who's the
already
first, second, third?
Message WhatsApp वरती मेसेज केलेला मला.
कोणी केलं? गायत्री?
हो.
गायत्री,
Sir,
I can't find.
इथे ह्या चॅट बॉक्स मध्ये पण केलाय सर तुमच्याकडे. Even on Zoom, I have texted you.
Okay, I'll see in the chat box. I think my internet is down.
Maybe Dr. Gayatri, you can declare
Yeah,
the
she can
result.
declare. She can declare. I'm not getting it on my
आणि
mobile
सर
also.
तुमचा व्हिडिओ थोडासा खाली घेतला तर बरं होईल. फेस हाफच येतोय. Yes, Dr. Gayatri, over to you for the results, please.
Okay, so I will declare the result now. As you know, the questions were really very interesting, and sir has explained so nicely. So there are a lot of doctors who have scored very nicely, and there are 7 doctors who have scored 10 on 10. But as we had already mentioned, the fastest finger, that is the doctor who has given all answers right in the least amount of time, will get the prize, and that doctor is Dr. Sagar Wade. Congratulations, sir. He has scored 10 and 10, and in a very short time. And there are 6 more doctors who have also scored 10 on 10. But as they have submitted the quiz a little late, they won't be given the prize, but surely they are winners. So we will like to announce their names too. Can we, Dr. Rupa?
Yes, please. Yes, sure.
Okay, so their names are Dr. Rajendra 211, Dr. BK Agashe, Dr. Sai Sanchar.
एक सेकंड. These are the email IDs because आपण email वरती सगळ्यांचे responses we collect ना. So these are email IDs. So attending doctors can identify themselves by email ID, and for whoever it is possible, they can write their name in the chat box. Say, so we will enjoy the names of all the other winners than the first one. So yes, Dr. Gayatri.
So again, I will give their names. The winner is Dr. Sagar Wade, and the rest of the names I will announce. Dr. Rajendra, Dr. B.K. Agashe, Dr. Sai Sanchar, Dr. Sandeep Kirad, Dr. Ashok Chauhan, and Dr. Zambre. Congratulations to all of you.
Dr. Sagar, it would be nice if you can send me your address, postal address, so that yes, I'll take down your number and we can communicate, and we will try to send the gift to you. It will be a pen drive and we will try to send it to you within, give us like 15 to 20 days ka time. By then we will send it. Yes, over to Dr. Prakash Mahajan, sir.
Yes, sir. Thank you, Dr. Shivaram Bonagiri. As usual, your lecture was really information-packed, very much useful for general practitioners, and you added much information from your practical experience also. For example, like giving steroid the day one when you suspect it is a viral infection, even if it is bacterial. There are so many practical tips out of your own experience, which won't be seen in the textbooks. That was one thing. Second thing, what I realized was fever itself is such a huge topic. Doing justice to fever in a 45-minute lecture is not correct. Right? You'll all agree with that. Because so many fevers, and it is very important for general practitioner also. You know, there is some disturbance. Yes. So it is such an important topic for general practitioners, you know. आम्ही आमच्या याच्यामध्ये टर्म्स वापरतो जनरल practitioners मध्ये. स्लॅक आहे म्हणजे काय? देर आर नो फीवर्स अराउंड. सीझन आहे म्हणजे काय? देर इज फीवर रनिंग अराउंड. असं आमच्याकडे असं. सो फीवर इज सच अ इम्पॉर्टंट टॉपिक. सो आय कॅन सजेस्ट वन थिंग, देर आर सो मेनी. You cannot cover this in one lecture. I think Rupa and myself can work out. You can categorize these lectures into multiple lectures. Like for example, fear of short duration, fear of long duration, PUO, exanthematous fevers, fever associated with arthritis, lab diagnosis in fevers. You can have a very series of lectures on fever, and it is virtually endless. Then rare kind of fevers. So I think we'll talk to Rupa. We'll discuss it how we could do it, because. Do you agree, sir, that 45 minutes for a lecture like this is really adequate?
No, I don't think.
Yeah, because it's such a big talk and very important for us also.
Yes.
So yes. So thank you very much. You have been very informative, and this will continue, I will promise.
Thank you,
and
sir.
Secondly, thank you to all MCF team, particularly Gayatri, Jyoti, Jayasri, Rupa, who have been organizing this particular monthly lecture series for doctors who are interested in the activities of Muktaa Charitable Foundation. And I was really delighted to hear from you, Dr. Bonagiri, that you are interested also in psychology because your wife is a psychologist, and then of course that gives a very big boost to do our work very comfortably. Thank you very much. And of course, thank you very much, all the participants. You have been attending all kinds of lectures that we could in hundreds. Now the count, Rupa said, was 100 and 124. So that's what really inspires us to continue this lecture series. Thank you very much.
Thank you all and have a good evening.
Thank you once again. And so we'll end the session for today, and we'll come back to all doctor friends with such nice lectures in future. Have a great evening. We'll end the meeting.